Okay, let's get to it. Our next agenda is a vital session titled Policy and Regulatory Reforms to Improve Healthcare Accessibility and Quality Lessons from Successful Models. In this discussion, we're taking a closer look at how strategic changes in policy and regulation can significantly enhance the quality and reach of healthcare services. So important. Our panel of experts will draw from a wealth of successful global models to illustrate this transformative power of thoughtful reforms. Let's give a huge round of applause for our session's moderator, Linda MacDougall, owner of MacDougall Consulting for Disabilities LLC, and of course, our panelist. Please come on up.
We have a panel of very intelligent and very wide-ranging in ages. I love it because we have a whole range here from many years. So, oh, we're squeezing in for a picture. Okay. I'm going to let our panelists introduce themselves and what they do, and then we'll get on to the questioning.
Okay, good morning. My name is Bob Carr, and I, along with my wife Ann, am a founder of a nonprofit named Common Courtesy. So, how did that happen, and why are we here? Uh, Flashback to 2005, way back to 2005. Ann and I were in a parking lot and noticed a large group of people coming out of a center, and the lady in front had a walker, and she put her walker in the back seat, and then got in the car, put it in reverse, and backed up, and nearly missed about 10 people who were coming out behind her. And sadly enough, that was a driver recertification program that they were coming out of. So Ann and I looked at each other and said, somebody's got to do something. Somebody's got to do something. Not everybody should be driving. So fast forward, now we not only provide transportation systems for seniors, but for healthcare providers. To date, we've been responsible for a little over 700,000 trips to and from healthcare and other locations, quality of life included, social determinants of health included. One county itself has funded over 20,000 trips for medical purposes only. Um, and we'll tell you more, but the point is we're here to connect healthcare to the recipient. You're brilliant people out here, but if you can't get people to you or home, then you can't use your skills. So we'll talk more about that.
Great. Good morning, everyone. I am Pratiksha Gupta. I am the founder and CEO of One Special Place, which is India's first pioneering teletherapy organization. We started One Special Place with a single objective in mind to break barriers of accessibility, to provide life changing therapy options for people based in remote areas in the country. Currently, we are into the 10th year of our operations, and we have helped more than 60,000 families. And we provide speech language therapy, occupational therapy services, mental health services, special education services, and diet and nutritional health services to people who are privileged and to unprivileged people who have disabilities and challenges and special needs. Personally, I am a speech language therapist and audiologist myself, and I undergraduated from India, but I did my post graduation from University of London, where I worked for a while before returning home. And it's always been a mission and a drive to help people. And I think accessibility should not be an afterthought. So that's what we've been trying to do with our organization. I'm looking forward to connecting with everybody here. This is my second Health 2.0 conference. I attended the one in Dubai last year.
Hi, everyone. First of all, thank you so much for being here. We know that we are one of two things that are standing between you and lunch. So we really appreciate you guys listening to us. Is it off? Is it on? Is it good? Okay. Technical difficulties, we got this. Okay. Hi, everyone. My name is Shahita Desari. I am the founder and executive director of Project No Bounds, which is a nonprofit organization championing hygiene and sanitation equity in underserved communities. We are a youth-led organization and have been able to mobilize hundreds of youth across the country to collect, package, and distribute hygiene kits to thousands in underserved communities. I am also currently an undergraduate student. I'm a second year undergrad studying brain and cognitive sciences, biology, and anthropology at MIT on a pre med track. And I'm also very involved in the health equity and advocacy space. So I'm looking forward to speaking a little bit about that and the effect of younger generations on these um, really critical aspects of advocacy today.
Excellent. Saludos familia, mi nombre es Jesús Suárez, CEO and President of Renaissance Medical Group. Renaissance Medical Group is a holistic company where we combine many services together, such as primary care, mental health, pharmacy, physical therapy, transportation, food. And we believe that combining all these services together, we can create enough data to make a difference in patients' lives. So I'm very happy to be here today talking to amazing people that can change everything that's happening right now.
Good morning, or maybe almost afternoon. My name's Karen Niven. I am the president of the Association for Healthcare Value Analysis. I am a nurse by training. I am a nurse through and through. And so it's really my privilege to be here with these fine panelists to really talk about that connectiveness. I've heard all of them. One of the themes is really around connectiveness. And you might be wondering, well, what does value analysis do in the healthcare? And it is a connector so that we can work together from the inside to fix and make healthcare more sustainable and more affordable. So it's my privilege to talk to you today.
Thank you. What an exciting group of people to be here for this panel. So, my name is Dr. Julie Wilson. I'm a family physician in British Columbia, Canada, and I am the founder of Terra Nova Medical Clinics. We, at the end of this year, will have 6 medical clinics with over 42 primary care providers. We currently serve over 50,000 patients, and I've been working together with the government, the health authorities, and the primary care networks to improve primary care in our region. I'm a strong advocate of primary care, and I combine it with entrepreneurship to actually build ethical workplaces that prevent burnout, improve patient care, and really recruit more primary care providers to Canada. So currently, we've won many awards like Outstanding Workplace of the Year for the city. We're Great Place to Work certified. We have a lot of benefits, extended medical, 100% top up maternity, paternity for a year, and amongst other things, just to really fix a lot of those problems in healthcare that has caused the burnout, that has caused a lot of the healthcare problems in modern day medicine.
And hello, I'm Linda McDougall, and I'm a senior health advocate, a specialized senior massage therapist, and an author and a speaker. And we could go on because I've lived 75 years, so there's a lot there. But I will start my questioning with Bob here. What, in your opinion, should we better recognize on the largest barriers to access to healthcare for all?
Great question. Great question, Linda. Another 75-year-old here. I think that recognition of the barriers comes in particular in our world, in transportation to and from receiving care. Once again, if people in need, it doesn't matter what the need is, health equity, food, deserts, whatever, if they can't get to and from for whatever reason, then they can't receive care. And we need to really convey that message as a team, as a group, that the transportation issue has been looked under. we just assume that people who need health care can get to the location. And that's a bad assumption because a lot of people are at home. A lot of people are desperate. A lot of people are in isolation. A lot of people need to get transportation efficiently and affordably. And so we all need to collectively be aware of that integral part in between. If I've got a minute, I want to read you something that has stood out to me for a long time. It's a quote. It's a quote by Mother Teresa. I had the most extraordinary experience once in Bombay. There was a large conference about hunger. I was supposed to go to that meeting and I lost my way. Suddenly I came to that place, and right in front of the door to where hundreds of people were talking about food and hunger, I found a dying man. I took him out, I took him home. He died there. He died of hunger. And the people inside were talking about how in 15 years we will have so much food, so much this, so much that, and that man died. What we're saying today is for us to emulate that, to not just throw thoughts at it, but to throw action and dollars at it.
Go ahead.
Diksha.
Pratiksha, I'm sorry, this is why they introduced themselves. What are the key reforms in India aimed at improving healthcare accessibility and quality?
Right. Since we are a global audience here, I think I take the privilege to talk about my country in terms of healthcare made more accessible and better in quality. So, we all know India is the most populous nation in the world, topping the charts with 1.7 billion people. And I think that's one major reason why it is more important today to make healthcare accessible to all those people. So, the Indian government has been doing a lot in terms of various reforms and policies. And I think there are four key areas where we are seeing a lot of changes back home. The first one is health infrastructure. So, a lot of emphasis is being given to creating more health facilities and wellness centers. And we have the scheme called as the Ayushman Bharat, as per which more and more health and wellness centers are coming up across the states, which provide free diagnostics, free medicines, all types of disease management, and even maternity and childcare services. The next key area is the health education. So we all know that the quality of healthcare depends intrinsically on the quality of health education and the quality of doctors being trained. So that's another big impetus area which is being worked upon. And there are new medical colleges with more seats and better technology being used to basically for capability building. The third key area is obviously the insurance policies or the coverage, which is, I think, a very big worry. Sadly, I quote a study in India, we have only 37% of citizens who have any type of health insurance. And so the government has a huge uphill task to manage this. Under the Ayushman Bharat scheme, we have a great policy that's come up, which covers the bottom 40% of the population with free health coverage. And I think that's amazing, considering the number of people we've got. And lastly, a key sector is something which has seen a huge surge in the recent times is digital health. And as we all know that India is the IT hub and riding the same wave, the digital wave, we have the Ayushman Bharat digital mission. which aims to bridge the gap between urban and rural cities using telemedicine and telehealth and DigiDoctor, and there are various apps, as well as creation of unique health IDs. And it's all a digital health ecosystem which we are building. And I'd like to share that we have a free government app called the e-hospital, which recently recorded more than 30 million free consultations. So there's a lot happening in the digital ecosystem as well. And there are challenges, of course. But I think the government is more pushed to making healthcare more accessible and better quality.
And I'd like to say that, Bob, you bring up a good point because I fell in 2020 and damaged this eye permanently. And so I don't know how much longer I'll be allowed to drive. They're giving me a 2-year.
We're there for you.
We're there. We're there for you too, because that's a great service and it's badly needed. I live with a lot of seniors and it's massive. Okay, let's move on to Shritha, right?
Shrihita.
Okay. What role can younger generations play in advocacy and policy making to drive health equity?
Yeah, I think I'm having a really great time at this conference, but one thing I keep experiencing is when people ask me how old I am and I tell them that I'm 19 years old, they're like, why are you here? Like, oh my God, why are you 19? What? So, and also we had a really amazing panelist yesterday, um, an adolescent medicine physician who said that his target patient population is 15 to 24 years old, and he doesn't think that anyone here is within that age range. Well, maybe I'll reach out to him to get some services. But I think that's a really salient point in that younger generations really deserve not only a seat at the table to listen in on different health advocacy and policy decisions, but have an active role in driving those. There's a really key metric that over half or about half of the world's population is under the age of 30, but 2.5% of global parliamentarians share this demographic. And so if you aren't including the people that your policies are directly affecting, how will you know how impactful they are in their application? Um, so I think in terms of youth mobilization for different advocacy efforts, the power of grassroots organizations and community organizing should not be um, counted off. With the advent of the pandemic and with in-person restrictions, I think one thing that we saw was this pretty explosive boom in grassroots organizations and virtual nonprofits rolling out with topics that youth populations were really interested in and were really passionate about: AI ethics, health advocacy, climate change, so many different aspects and advents of health and different aspects of society that people really wanted to drive change on. And weren't given the opportunities and didn't see those opportunities in the current societies that they were living in. So they decided to just create them themselves. One thing that you'll see with a lot of youth populations is we have this really key power in our back pocket called creativity. If there is a limitation or something, a restriction with a certain program or with a certain policy, we'll find a way to circumvent it. We'll find a way to go around it. So I think that really leveraging that power and including youth in very key decision making environments is very important. I think Bob's quote was really salient in that there was this conference happening about hunger and about how they were going to solve hunger, but the people that were being directly impacted by that were suffering outside of it. And I think you see something like that with younger populations as well. You can have all of these different forums and different places to talk about all of these really key issues, but you're not including people that those issues are affecting. No offense to this conference, this is something that happens everywhere. I know that there's a panel tomorrow on mental health in underserved youth populations. But how many people on that panel are under the age of 25? How many people are directly in those populations that are being impacted? And those policies that they're talking about will directly impact their way of life. So keeping these in mind is very key to being able to drive successful change because key health or successful health solutions have to be as dynamic as the populations that they impact and as have to include the populations that they impact. And there are a lot of programs in both the US and the world. There are like various youth delegate programs, but usually they will just have a designated seat at the table. This is our youth delegate, this is our youth observer, and they will listen in on these policies and they will have a great experience being such a young person at this really wide ranging platform. But they aren't given a voice and they aren't given the opportunity to provide some of their own say on those topics. So, really keeping that in mind and the fact that we are called the future generation, but we exist right now. So, having us in mind as not just the promises of tomorrow, but as the actors of today is something that's not only going to impact youth populations, but will have this really big spillover effect into other facets of society as well.
And I'd like to say that's very true for my demographics as well, the elderly and the disabled. So thank you. They need a seat at the table. That's one reason Bob and I are here. Go ahead. Jesus, according to your experience in the field, what has been the key to maintaining patient stability and what strategies have you used to provide this level of care to your patients?
That's an amazing question. I believe that we saw what happened when COVID came to us. I think everybody that is in the field understood that we have a problem, and we had a problem. To be able to build a holistic organization that can combine services and data is been the key because allows to see the patient in every angle so we can bring a solution in their life. When COVID happened, we were one of the only companies in the state of Massachusetts that we didn't lose one life and we never closed our doors. Why? Because of the data that we had in patients. Because we can combine our physician, our primary care doctor, and we can combine the information of our psychiatrist in their mental health. And now we can see how the nurse is seeing the patient on a daily basis at home. And now we can really create a program that fix every aspect of the patient. We believe that culture is key. Understanding the community that you're working on is key. And I think uniting all those tools together is has been the solution, and we have seen it. Something else that is been key is love. We have forgot that we are in the medical aspect because we love what we do, because we love our patients, because we want to make sure that we can see every angle. When we see love, we see solutions. And I think that's what Renaissance Medical Group has been all about. It's about combining data, loving what we do, and making a difference in a person's life.
Thank you for what you do. Karen, how have organizations such as the Association of Healthcare Value Analysis Professionals, or AHVAP, influenced the evolution of value beyond simply the product? What is the new core definition in value in healthcare that we should be striving to achieve?
That is a great question. And as I've listened to my colleagues up here talk about their experiences, one of the things that they could have been talking about value analysis, from the courage that it takes to the seat at the table to loving what you do, because value analysis is really about, as the previous panelist said, meeting our organizations and our providers where they are. So it allows us to work and have a seat at the table so that we can provide um, economical care. It's really about, and when you talk about value, what does value mean to us? When we go to the hospital, we expect to get, we don't expect to get good care, we expect to get excellent care. And so it's our job every day. And I'm so thankful I'm sitting beside Jesus here because there's nobody that loves what they do. I love what I do. I love what I do every day. And I love the opportunity to get to work with other providers and organizations. My day job, I work as Linda said, I'm the president of AVAP, but my day job, I work for Premier Healthcare Alliance, which works with hospitals across the country. And I think one of the things that we do with our member organizations is we help them look externally and internally. Because being a nurse, I've been um, the president of the ANA, which is the American Nurses Association, many years ago, opened the ANA conference with this quote. She said, "I've looked in the mirror and the enemy is me." And that is so reflective, I think, of how we have to approach what we do. We all have a part in it, especially as we've gone through these 4 years of product disruptions and back orders and the things that not just the care that our organization providers need to provide, but where's the product going to come from? You know, I came out of the OR in the perioperative world, and a surgeon holds out his hands, and you put what he wants in it. And can you imagine being in that OR, being in those places where that surgeon puts out his hand? And you might not have what he needs to go in it. So it's really an opportunity for us to look at how do we make our organization sustainable? Because the tool belt, I talk about our value analysis tool belt. Our value analysis tools today are not the ones that we had 4 years ago, and they won't be the ones that we have in 3 years. Because as my colleagues have shared, everything's changing. And we have to be nimble enough as an industry to change with it. And I'll be the first to say why nurses are have a very special place in my heart. We're sometimes pretty I really like Diet Coke. I'm not liking this Pepsi stuff this year. So I have a preference. But is Diet Pepsi going to hurt me? No. Am I drinking it? Yes. So but I think that we have an opportunity to look in the mirror and really realize what part do I play in it? And how can we make our organizations stronger? And how can we personally have more courage to make the bold moves that I think we need to make going forward?
Thank you, Karen. Julie, could you share insights on innovative healthcare delivery models in your practice that improve care for vulnerable populations and how these models work and the impact made in your community?
Thank you for moderating, Linda. And it's very nice to go so far back in the panel and see so many of the issues that we've been working on actually reflected in all of your companies and solutions. I feel that we're all working towards the same goal. Um, One of the things that I wanted to bring up was primary care transformation in my province of Canada and the exciting changes that have happened since 2018 and the creation of our primary care networks. So, this is a huge policy and regulatory change that has significantly improved healthcare and provided a lot of success. So, the problem is primary care is quite fragmented. A lot of people are unable to access it. As Jesus noted, allied healthcare providers are not necessarily connected. There, as you noted, as our youngest panelist, that young people are not at the table. The populations that we are serving are not getting the voices that they should. So these primary care networks were built with a geographical area and servicing about 50 to 100,000 people. And what they would do is combine resources and make culturally appropriate, population appropriate decisions to use funding to improve primary care. So, as an example, 17% of people didn't have a family doctor. Of those who did, 44% couldn't access them in a timely way. Many people could not get after hours care and would go to the emergency. Emergency room visits were going up. Inpatient hospitalizations were going up. Complex care for complex patients was not being done correctly, and that would increase again emergency visits costs, inpatient visits. So what these primary care groups did was create urgent and primary care centers so you could have access to a primary care provider 24 hours a day, recruited 600 extra primary care professionals to work into the province. We use those networks to add allied healthcare providers free of cost to our patients. So in my own clinic, we have an occupational therapist, a dietitian, a mental health counselor, a frail seniors team, a chronic disease nurse, and so much more. And that helps with our vulnerable populations who may find it difficult to access it, finding them online, paying for them, and all of that. They can just come to their family doctor's office and get all of that. So, what we've seen with the addition of these primary care networks is a huge improvement in access to primary care, reduced hospitalizations, reduced emergency visits, reduced specialist referrals, to the point that even two primary care clinics in Alberta, they were large, right? And over 10 years, they saved the government $120 million. Taking care of 40 people in this way is 22% cheaper than one patient in hospital for one day. So all of these things improve provider experience, patient experience, population health, and reduce costs. So that's been something that changed in my career. I see a huge improvement. It's only been a short period of time. It doesn't even cover the whole province yet. Soon it'll be 70% of the province. We're going to start to see this exploding over the world. We have it in the UK now. We have in other provinces. Other countries are starting to start these networks. And I think it's going to solve a lot of the problems we see in our day-to-day foundational medical care.
Thank you very much, Julie. Now I get to ask myself a question. How can we shift the focus from fear of repercussions to promoting a culture of safety, and should responsibility between licensing agencies and senior home administrators for clients' well-being? This is something that is very dear to my heart because as a special needs person, I have worked with several special needs places. I ran homes for United Cerebral Palsy years ago, and those adults got everything they asked for, basically, that was necessary for them to communicate, sit up straight, have their wheelchairs, everything. And my seniors don't get that. And this is why I am here today. Somewhere along the line, years ago, Title 22 came in and the Nursing Home Reform Act came in. Both of those had a section that talked about restraints. And for some reason, seniors, everything that could support them in their wheelchairs or just in mobility period, can be seen as a restraint, and often is. And so the licensing comes in. I can give you several examples. I had a dying dementia client that was getting massages. And I came in one day and her bed was practically on the floor. There was no railing, and there was just a mat there for her to fall out on. And I asked the staff, what's going on? Well, licensing had come in and said that railing was a restraint. I'm sorry, it's a safety device. And this goes on in almost everything wheelchair related in the senior homes. You can't get a seatbelt, that's a restraint. They don't see the patient slide out like I do and onto the floor. And this is especially impactful with osteoporosis clients. All it takes for them is one fall on the floor and their hips are shattered or more. So I'm sorry, there's a line that shouldn't be crossed about what is a restraint and what is a safety device for that particular client. And this is one of my other problems, is they're putting a one size fits all around the topic instead of what's good for this client, a client centered focus. And one of the ways I see this being addressed, the licensing doesn't understand the home or the clients, particularly in many cases. So maybe they need to be trained together. If they're trained together, they learn to work together. And if they learn to work together and understand each other's issues, because I've been told by licensing, well, if you want these changes, then you're going to have to change the law. Well, no, it's not the law that's the problem. The law has to be updated, granted. They're both old laws, and we're changing rapidly, and we need to change some things in it. But the law itself gave permission for restraints versus the other, and they're not using them. And I think the homes aren't using them for fear of being shut down or fined or whatever. Because I've talked to a few of the administrators, plus I was one once. And I must admit, they can be scary. The first one that came in when I was a brand new administrator for UCP chopped and chopped and chopped. Now, granted, we were in dire straits when they hired me, but still, it was just nerve wracking for her to come in. Well, it was nerve wracking for her too. She had a nervous breakdown 2 months later. After that, I got the solution. I got licensing people who were educators, who were supportive. And through my 11 years of running that program, I went from bottom of the heap to one of the top of the heap because I had the support of licensing. So licensing needs to get its little act together, I think. And with that, I will see if there are any questions out there so you guys can go to lunch. I can't see, so no questions? Okay. I don't see them, but if somebody can see them. It's not only a disincentive, it is mind boggling to try to match that all together. And that's one of the problems too. You've hit it on the head. I went to my local legislators and none of them were that interested. They just said, that's not our problem. I mean, they were perfectly on board, but they said that's not our problem and that's not something we can't work on. So that's as far as I have been able to go at this point. Bob, any?
Um, couple of examples of that and talk about transportation. During the COVID pandemic, the city of Atlanta hosted COVID shots, vaccines, but couldn't get anybody there. So what did they do? They reached out to us and said, "Can you go into the neighborhoods? Can you gather people and bring them to the stadium for vaccines?" So a lot of good there. But the light is beginning to turn on. They're beginning to connect the dots, as you said, that to get assistance, to get healthcare, you need to be able to get there.
Anybody else here?
I want to add something. We live in time of changes. We need to be aggressive. This is our time for us to be able to talk and speak and be able to make a difference. Talking to your Secretary of Health of your state is important. You need to have that communication. Be able to create teams around you that they need to listen. They need to listen, and we need to make changes. So the whole reason of being here all together is so we can put our mind together and we can make a difference. So I advise you, don't look at the wall. Look how you're gonna break it and how you're gonna get to the other side. It's time to us to get more involved in the political aspect. There's a lot of legislations, there's a lot of regulations that now is the time to break because we live in an emergency time. So let's make it happen.
And advocacy has no age restriction, so anybody can do it.
I wanted I wanted to add, to the question about advocacy for legislation to improve, these healthcare
Can
things.
we take that privately because we're being told our time is up and you guys are wanting to go to lunch? So can we talk about that privately?
Oh, okay. Um, what I find as a doctor is that we're experiencing a lot of changes from the self-regulatory bodies, such as the Nursing Association, the Physicians Association, and recently, for example, our nurse had said we refuse to take care of more patients than this per this level of acute care. So rather than the legislation doing it, they decided to do it themselves. And by doing that, they improve the quality of care through basically union action. And that's how I'm seeing it in my own environment. And then that allows us to advocate. As a doctor, I can advocate to my own regulatory body. As a nurse, they can to theirs as well. And that's where I'm seeing most of the change.
Okay, we're going to say thank you very much for staying as long as you have and listening as nicely as you have. We're all appreciative.
And another round of applause. Thank you so much, guys, for your